Well, welcome everybody. I see some new faces in the crowd, at least in the participant list. That's great. Welcome. We glad to have everybody. Tell your friends and join our YouTube Zoom channel. We'd appreciate that. Today is Rush University Medical Center Division of Nephrology Biopsy Conference for July 29th. Today's CME activity code is 483098. We have a great case. We'll have two polls. We want everybody to vote. Don't be shy. I think voting's fun. We have two simple questions about the case, so we want you to vote. The co-hosts don't need to vote it, and so we prefer they not. It risks shutting down the poll. As usual, the patient's been de-identified, and as usual, we have nothing to disclose. And if you want to get on our monthly mailing list, just send one of us an email. You can find us, and we'll get you on the list. If somehow you're not receiving us, let us know. We can't always tell. The faculty are able to be speaking. Everyone else is going to be muted. If you have something to say, send us a note in the chat, and we'll either unmute you or we'll address it through the chat. Without any further ado, Dr. Corbett's got a case. He's going to read the protocol to us. Take it over, Steve.
All right. So we have a 39-year-old Hispanic woman who's being seen for evaluation of chronic kidney disease. Her serum creatinine had been stable at around 1 milligram per deciliter with an estimated GFR of around 56. But in the 6 months prior, it had increased to 1.4 milligram per deciliter with an estimated GFR of 40. Urine studies, I don't know who's moving it. It's not me. Urine studies demonstrated no hematuria, proteinuria. Past medical history was remarkable for Raynaud's phenomenon, and she had been diagnosed with Sjogren's syndrome versus MCTD in 2013. She'd been treated with Plaquenil followed by rheumatology. She was diagnosed with hypertension in 2015 and placed on losartan for this. The most recent serum creatinine was around 1.3 with an estimated GFR of 48. Urinalysis done at that time had no protein or blood by dipstick. And to further evaluate the cause of her progressive renal disease, she underwent a renal biopsy in 2016. Past medical history was Raynaud's phenomenon, Sjogren's syndrome versus MCTD, as we talked about, in hypertension. She'd also had a gastric bypass surgery 10 years prior for obesity. She'd had a cholecystectomy as well as a hysterectomy. She had no allergies. Plaquenil, she was on Plaquenil, losartan, and a multivitamin. She didn't abuse NSAIDs or COX-2 inhibitors. She's married with 4 children. She's a former smoker, but hadn't smoked in years. She does not use alcohol or illicit drugs. Her family history, her father has diabetes type 2, mother with CAD and hypertension, both alive, brother with gout and had end-stage kidney disease and was transplanted at the age of 40. A second brother with gout had CKD and was on a transplant list. A maternal uncle had CKD and died at the age of 65 due to quote unquote kidney failure. And she has an oldest son who is being evaluated for elevated serum creatinine. Her review of symptoms are remarkable only for dry mouth and some fatigue. She has no history of reflux, nephrolithiasis, or pyelonephritis. Blood pressure on exam was 117/79, pulse 62, height 5 feet 4 inches with weight of 163 pounds and a BMI of 28. Her exam was pretty unremarkable. No rashes. HENT exam demonstrated no real ulcers in the mucous membranes, but they did appear dry. No adenopathy or thyromegaly on neck exam. Lungs were clear. Cardiac exam normal. Abdominal exam normal. She had no pretibial edema, and the neurologic exam was normal as well. Her laboratory data at the time of the biopsy: sodium was 139, potassium 4.3, chloride 108, bicarb 22. BUN 26 with a creatinine of 1.3. Glucose, total protein, albumin, calcium, LFTs were all essentially normal. CBC, a white count of 7,400 with a normal differential. Hemoglobin was 10.2 with an MCV of 87, and her platelet count was 253. Uric acid was 3.7. Urinalysis had a specific gravity of 1011 with a pH of 6. Again, no protein or blood by dipstick. The urinary sediment was within normal range, and our urine protein creatinine ratio was actually normal at 153 milligram per gram. There was no urine albumin creatinine ratio at that time. Serologic evaluation, SED rate, CRP, rheumatoid factor, double-stranded DNA, SM antibody, RNP antibody, SCL70, SSB, anacardiolipin antibody, beta-2 glycoprotein 1 antibody, lupus anticoagulant, ACE level, Hep B antigen, Hep C antibody were all normal or negative. She did have a mildly elevated ANA at 1 to 80 in a speckled pattern. Her C3 was mildly depressed at 69, normal being around 81. The C4 was 13, normal being around 15. The SSA was greater than 8, with a normal less than 0.9 AI. Renal ultrasound showed essentially normal sized kidneys with increased echogenicity. There was no hydronephrosis and no renal masses. And again, in 2016, a renal biopsy was performed.
Great. Any questions for Dr. I have one, Steve. The patient herself had no history of gout,
None at all.
but there was this in the family. Okay. Any other questions? Great. We're going to start with
a gastric bypass. I'm sorry. No PPI use or H2 blockers.
No, it's a good point. No, none that I could see. And I went back through the chart in preparation for this. I saw no PPIs and no H2 blockers.
Great. We're going to start with a poll here. Now, you don't have to worry. This is a second opinion. So this patient obviously got a biopsy because it's biopsy conference, but you don't have to worry about offending Dr. Corbett because it was a second opinion. I want to see if everybody would biopsy this patient.
I also don't think that we ever need to worry about offending Dr. Corbett. He can't be offended. When you're perfect, there's no way to offend anybody.
Oh my goodness.
That's one explanation for not being offended.
Man, the arrow just went right through my heart.
From Cupid.
Let's get some more votes. We won't tell people how this is going, but it's an interesting answer to me. Still coming in a little bit. Okay. That's good. You can you show it?
Yep. Share results.
Okay. So everybody see that? 2/3 said yes. 1/3 said probably no, which I find very interesting. Dr. Gashty, how do you feel about the poll? How do you feel about the question? And how do you feel about the case?
I think it's a little surprising. The poll is the percent of people that wouldn't biopsy. It's really kind of a renal failure of unknown etiology. So I would biopsy, but you can also, based on what I guess we'll discuss as far as what the differential may be, you may find something that is treatable, but you may also find something that's not treatable. So I think at the end of the day, I would want to know if there's anything that I could prevent or reverse or slow down. How do I feel about the case? So 39-year-old with a pretty strong family history of kidney disease. That to me really stands out, that there's such a significant amount of family history. And she also has, Sjogren's, Raynaud's phenomenon, positive ANA, elevated SSA antibody. So the sort of things that come to mind with Sjogren's would be more of a tubular interstitial disease, as well as cryo. Cryo is probably cryoglobulinemia is probably from the autoimmune diseases. Sjogren is probably the #1 cause of autoimmune disease mediated cryo. So that's on the list. Tubular interstitial disease from Sjogren would be one thing, but also since she has this family history with gout and renal failure, and she has elevated creatinine, all of these uromodulin mutations causing tubular interstitial diseases can also be causing this. Not that we would necessarily see that on a biopsy. That would be more of a next level sort of family history and genetic testing. But because of lack of hematuria and proteinuria, I think this is going to be more like a tubular interstitial process. She only has 130 milligrams of proteinuria. The complements, the C4 is a little low, but cryo doesn't necessarily fit, but I want to keep that on differential. Lupus, obviously, anytime we're talking about autoimmune and mixed connective tissue with a positive ANA in a young Hispanic woman, lupus has to be on a differential. But if you think about the various lesions of lupus, they usually have either proteinuria or hematuria, and she really doesn't have a whole lot of either one of them. So I don't know if she would have nephritis even if she does have systemic lupus. So I'm going to stick with, because of the family history, I'm going to think about a genetic disease. So we're going to see probably tuberous disease, and then we're going to have to figure out how that's related to the family history. And then I'm going to think about interstitial nephritis, and then third, probably cryo, and fourth, lupus.
So, Bill, Casey, Dr. Gash, said he was surprised how many people would not biopsy. I actually, when I said I was surprised at the results, I felt the other way, that 2/3 would biopsy. Here's a person with, with a benign urine. They have no proteinuria, no hematuria, some hypertension. What do you think, Bill?
Yeah, I certainly think that with that story that you just said, if you have a benign urine, the creatinine is not even that elevated. Certainly there is a reduced GFR, but she has known Sjogren's. Maybe I think that her family history and her history of Sjogren's and possible lupus is what would tip me over the edge to biopsy her. Certainly, I've seen patients just like this without all the past medical history stuff, where they have a creatinine of 1.3 and a bland urine and no proteinuria. I don't biopsy them. So I think looking for something reversible, knowing that her medical history is kind of so positive for things, would probably tip me over the edge to biopsy. But I'm 60-40 like the poll, as opposed to 90-10 on that. I can see the other side of it. What do I think that she has? I do also think that there's a tuberous pattern here that's going to be most likely. I wouldn't really even include glomerular disease, and I'm not sure I would think of cryo that much when in the absence of hematuria. Of course, it could be there, and the urinalysis isn't always that accurate, but I'm really would lean more towards tuberous disease, which we always think about as medications induced, but with this family history, all the tuberous uromodulin mutations and all that would be higher up on the differential. She also has Sjogren's, and that can be interstitial nephritis. And you also look, and she looks to be what has at least a mild distal RTA based on her electrolytes and her urine pH. She's got a little bit of an inappropriate alkaline urine, and her bicarb's 22. She's hypochloremic, and that would fit as well. There's familial distal RTAs as well, and some of those are associated with deafness. But she doesn't have kidney stones, and so we don't really have a complete story for it, but it's just sort of really still smelling like some sort of familial tuberous disease to me. And so I think that the renocyte testing is going to be very helpful in this case, no matter what we see on the biopsy. But I think realistically on the biopsy, we're going to see quite a bit of tuberous disease, maybe some secondary global sclerosis, but I don't think the immunofluorescence will be positive, and I think the EM will just be kind of chronic scarring.
So she had a gastric bypass. You're our stone guy. You think she could have a chronic tuberous disease from hyperoxaluria with this kind of presentation?
It's funny. I actually wrote down gastric bypass when I was thinking, because I was thinking if anybody's a setup to get stones, you already have Sjogren's, you have what looks like a distal RTA, and then you get a gastric bypass. Now, why not just add Topamax to her medication list and just give her a triple amount of having stones? But she doesn't have stones on her ultrasound, and so I think she's kind of okay. But chronic oxalate, I think there's been a couple cases of massive oxalate ingestion leading to kidney failure. There's the iced tea nephropathy in the New England Journal of Medicine, but typically we don't see as much renal failure from our gastric bypass as much as we do in some of our other patients with bad inflammatory bowel disease due to not only volume depletion, but also some oxalate deposition. So
they can also get nephrocalcinosis, right, from the oxaluria.
Yeah, I do have a patient.
Yeah,
I have a patient who had a bypass years ago and just had progressive renal failure. No one thought about it, and sure, she had chronic, maybe a stone or two, but her real problem was chronic hyperoxaluria with renal oxalosis. So that was brought up. There's a lot of great ideas in the chat. I'm not going to bring them all up, but kudos to everybody who's thinking about those things. I think you're all spot on with your thoughts. Somebody's making a very good inside joke about kale, and so I'll just say kudos to the joke and leave it at that.
The type of gastric bypass, do we know? Was it just a sleeve or a Roux-en-Y or something? Just because that makes a difference on your oxalate absorption.
Yeah, it makes a huge difference.
Yeah,
we don't know.
We don't know. I mean, whether the ileum was bypassed or not, essentially, where she'd have fat malabsorption. So yeah, we don't know that.
Bill, what about hypertensive nephrosclerosis, whatever the heck that is?
Yeah, I don't even know if we're allowed to say that anymore. I think it's kind of a bad word nowadays. It certainly can exist, right? I mean, her blood pressure's pretty darn good.
I mean, we don't know what it is, but we still have 40% of our dialysis patients carry that diagnosis. It may not be hypertension, but isn't that kind of how they present with a pretty benign urine and some hypertension and renal failure?
Yeah, and there may be some vascular disease and then some global sclerosis, and it might be hard to even figure out what's going to be what if that's the case. I usually think that their blood pressure is a little bit more uncontrolled for longer. It's hard for me to imagine a 39-year-old with a normal blood pressure now presentation, even though she is almost starting having that. But I think anything's possible.
Anybody else have any thoughts about a differential here? Any other genetic diseases? What about ALEC2? Casey?
ALEC2, as far as I know my name's not Casey, sorry. Casey.
Bill answers for everybody.
Yeah.
And she is Hispanic, so I mean that it's seen more in that demographic of population, I guess.
Yeah, they don't have to have proteinuria, right?
It's predominantly an interstitial amyloid, right, Steve?
That's right.
What about the genetics of that? Is it this strong? Or is it more it's more polygenic, right?
It is, I mean, Bill's probably
lacking here is.
I know Bill's I've had one case. Bill's had a few, I think. At least I think I had one in retrospect. But I saw some papers where there were siblings that actually, had ALEC2. I don't know if it's just serendipity. I don't know that I've seen anywhere where there was any autosomal inheritance, more or less. Go ahead, Bill.
No, I agree. The ones of the amyloid we think about that are more hereditary, transthyretin and some of the other ones, but ALEC2 is not as genetically linked, but there is clustering.
Well, I think that's a really good point. It's a really good point. It has an ethnicity to it, but not necessarily a hereditary nature to it. I think that's a really good point.
Well, the fibrinogen A alpha amyloid definitely affects the kidneys. A lot of the other amyloids are more polyneuropathy and heart failure, but they can occasionally have kidney involvement too. But anyway, it's a thought. I mean, she is Hispanic.
Other genetic diseases, if we were thinking about a lot of the genetic diseases we think about are glomerular, and that's why I didn't really bring up too many of them. I mean, it could be something like Fibrosis. It hasn't been brought up yet, but again, no rash. I mean, this would be very unusual. That technically is a podocyte disease, although they present with low-grade proteinuria. So, and with hematuria, and we don't really have that either. So that's something to consider as well.
Yeah, so the gout to me is just a big clue, and that's kind of what's sticking out to me. The gout and the renal failure, like thinking about a autosomal dominant tubular interstitial disease, and it fits that kind of autosomal dominant pattern with at least in the genetic history here. So unless anybody else has any other ideas, let's give our second poll. So, what do you think the biopsy will show? A, ALEC2 amyloid. B, oxalate nephropathy because of her bypass. Hypertensive nephrosclerosis because of her benign presentation. Sjogren's syndrome with chronic tubular interstitial nephritis. Or E, something else. Give it a little time. The wording actually might be, what do you think the diagnosis will be, more than what will the biopsy show? So still, I think you get the idea here. Some of these are very specific. Some of these are not specific diagnoses pathologically to make a diagnosis. So we have a couple more coming in. We have 32, 33 people voting. All right, Pravir, you want to show the results? So this is great because this is why we do biopsies. And I think maybe people that voted for a biopsy are vindicated here because we have a whole different host of diagnoses. We have 10% ALEC2, 25% oxalate, only 10% hypertension, which I'm surprised. And 52% are putting this on her chronic Sjogren's, and less than 10% say other.
So why are you surprised about the hypertension? I mean, she only had it for a year prior to the biopsy.
Well, maybe I didn't pay attention to that, Steve, which is, which is totally valid, except that I don't always trust people's history of,
Fair enough. So
of diabetes and hypertension. We just never know that. And whatever hypertensive nephrosclerosis is, it doesn't seem to correlate strongly with the level of blood pressure anyway. So
No,
that's
but
my cop out. That's my cop out for not paying attention to the
I get
protocol.
it, but so-called benign essential hypertension, whatever you want to call it, those people really didn't develop renal disease until they were much older, right? They'd had their hypertension for a long time.
Well, it kind of depends on your ApoL1 status too, but
Well, she's Hispanic.
she is Hispanic. That doesn't rule out ApoL1, but I'm balking on everything for you. So you're absolutely right. Let's spin the wheel. Oh wheel, who shall read the biopsy? Well, Dr. Corbett can't. It's his case. We all say the wheel knows, but the wheel is wrong. All right, awesome. Awesome is one of our second-year fellows.
All right, so this is our first slide. This is a low-power trichome stain. We're basically looking for any chronicity with the bluish material here. And then we have to look if the tubules are back to back. So I do see they are kind of spaced apart. I do see some degree of bluish material and, some maybe inflammatory cells in the interstitium as well. So I would say maybe 30%, 30 to 40% fibrosis.
I think it's a little low. I mean, if you look, there's almost no tubules there, and there's a lot of blue. So I'd give it well over 50, maybe over 75. I mean, that's pretty striking to me, the lack of tubules there.
Yeah, I mean, the atrophy as well. I mean, most of those tubulars atrophic, there's one little island down there just south of the middle that has what looks like viable, but all the rest of them, as Roger said, they look atrophic and a lot of blue staining material.
All right.
How did whoa, go back. Not that far back. What do you think about the glomeruli?
So it's hard to comment about the glomeruli on this magnification, but overall, I do see they're pretty cellular. I can see in this glom, I do see there is like a prominent Bowman's spade. I don't really see any crescent, at least at this magnification, but they do seem pretty cellular.
So here's the real question. I know it's kind of rhetorical. You see all that fibrosis and all that atrophy. Aren't you a little amazed that the glomeruli look that good?
Yeah, that's true. You would expect that the gloms, like you're saying that you should expect some scarring in the gloms as well with all that tubular scarring.
For sure.
What's the major disease here? Is it glomerular or tubular interstitial? That's what he's getting at.
So this is predominantly tubular interstitial.
So you can't see that kind of tubular atrophy without, which usually occurs after glomerular senescence. So what he's pointing out is the fact that this looks like a predominantly tubular interstitial disease. The gloms there look pretty damn good. Yeah,
I mean, out of the 4 gloms, only the one down at the bottom looks like it might be developing something, which you will see higher power. So there's some periglomerular fibrosis there, but the other 3, given the fact that at least 75% of this core, at least what we're seeing, is pretty scarred down. Anyway, so that's exactly right, is that this seems to be predominantly tubular interstitial.
And that shouldn't come as any big surprise given our discussion about the case with the lack of hematuria and proteinuria.
Exactly.
All right, so this is again a low power H&E stain. I see again there is a lot of scar tissue in the interstitium. And again, the tubules kind of do look atrophic here as well. So again, it kind of corresponds with we just saw. on the trichome stain here, there is another area just right at the top where we do see a lot of inflammatory cells, more so in the interstitium as well. Then I have high power H&E stain. Again, I have a glom in the middle. The glom overall looks pretty healthy to me. I don't really see any scarring there. The glomerular capillary tufts seem to be pretty patent. I don't really see any mesangial expansion or hypercellularity either. More so, if I look more towards the 6 o'clock, I do have a tubule here. And then, yeah, but predominantly, I think I should say that the glom overall looks pretty healthy in this slide.
Great. Yeah. I mean, I think it's real important because, you know, it gets back to our first point about what's going on here. These globs look pretty good.
Yeah. So here again, we have probably a medium magnification of H&E stain. Here I do see, I'm not sure if this area is all scarred just around the glom. This,
So what do we call that? Call that periglomerular fibrosis?
Periglomerular fibrosis. Yeah.
Yeah, it just means that there's, you know, a lot of severe chronic disease there. I don't know if it's any specific, but I think it's a marker that glomerulus is on its way out.
Okay. Sure. Yeah, so I think that's the most striking feature here. Rest of it, again, we do see a lot of, you know, scar tissue again in the interstitium. Again, around 12 o'clock, I do see some inflammatory cells here. Mostly looks like lymphocytic predominant infiltrate here.
You know, on the very first slide of the trichome, you know, you really couldn't tell what was going on. There's just a lot of blue staining material and not many tubules. And then the next H&E showed, you know, a fair amount of interstitial infiltrate. But there's clearly a lot of fibrosis as well. So it's not a pure like acute interstitial nephritis. It's maybe a little bit of acute and a little bit of chronic interstitial nephritis. And I don't know with the relevance of that. I mean, certainly in Sjogren's, you'd be thinking about, you know, a lot of lymphocytes, you know, in the interstitium. But, you know, for everything else, I think we're still open. You know, we really don't have anything specifically screaming at us for a diagnosis here.
Again, I have our H&E stain. I have a glom in the middle that that does look healthy. I do see open glomeruli space here.
No, I think you're making a very good point because yeah, there are some, but there aren't as many as you know. It's not a normal glomerulus where you see a lot of open loops.
It's not as patent as we see in the previous slide, though.
Yeah, I think so. And then you know you wonder about a little bit of ischemia or something, and maybe hypertension or something.
Yeah, and again, periglomerular fibrosis here. You can see in this slide too.
Yeah, good point.
It's kind of almost hard to tell if this would be a mesangial hypercellularity versus just contracted and ischemic. And, you know, this could look like IgA nephropathy, but it could also look like something that's really just more lymphocytes in the mesangial area or more cells in the mesangial area than it actually is because it's kind of shrunken down. So yeah, I think ischemic's the right call, but it's a tough call.
I think that's a good point, Bill, because, you know, we didn't really bring up IgA significantly or at all. And, you know, she's Hispanic and that's all the first thing I think of.
Or even in mesangial lupus.
Yeah, good point. Yeah, she has positive serology.
The inflammatory cells are also predominantly lymphocytic. I don't really see a lot of eosinophils, even in this slide, which kind of sways me away from an acute interstitial process. It hints towards more a chronic process that would have like, you know, more plasmacytes or lymphocytes predominant. Right, so again,
you actually skipped that glom. I don't know there's that much more to show there, but the one before, but
let me see.
Yeah, you're going forward. Go back. Back.
Here, Asim, I will do it, Asim.
Okay.
Yeah. This one is another one.
Okay, yeah,
No, it's just this one here. I'm sorry. It just because you made the point about the open capillary loops. This one
Mhm.
actually that one actually looked a little better.
Mhm.
And you can go ahead and talk about this slide now. The PAS, next one.
Okay, yeah.
There you go.
All right, this is the, so we have this is the PES sustain, basically high power PES sustain. Again, yeah, this one shows again much open glomerular capillaries here as compared to the previous glom. Again, there is a lot of scar tissue around the glom. Here, I think there is a glom maybe around 6 o'clock that seems to be pretty sclerosed here. So this is the first one where I can see like pretty significant sclerosis of the glom as well.
Yeah, so I think PS was on sale this week because it's a pretty strong stain. But I love the PS stain because it gives you such a great idea of the architecture. Now, what do you think about the mesangium here? Does it look a little expanded?
Yeah, the mesangium does look expanded, especially around the 9 o'clock area here.
If you look at 10 o'clock there, right against the almost Bowman space, I think that's a vessel. I think
here.
that might be well, I don't see an arrow, but yeah, that exactly. That may be a vessel, and that could just be hyalinosis, which is relevant to the diagnosis of hypertensive nephrosclerosis. We don't have where typically the afferent has some hyalinosis and the efferent does not. So that may be what's going on there. Again, I'm not saying this is hypertensive nephrosclerosis or not, but I don't think that's just mesangial. I think that's a vessel that's taking off from the hilum. And we talked about ALEC2. Amyloid is typically PAS a week, and this PAS, whatever's going on, is pretty strong. I don't know how that would, but ALEC2 is also predominantly in the interstitium, and there's a lot of stuff in the interstitium here that I don't know what is going on. I don't know if it's just collagen or what. So, that may still be, from pathologically speaking, that may still be in our diagnosis, in our differential diagnosis. We'll have to see, of course, the Congo red on that.
Okay.
So we've really gotten kind of nowhere. I mean, we've ruled out a GM, but that was not high on our list anyway. I think everything's kind of still in the running.
Yeah, here again, this is probably H&E stain again, and I see 2 completely scarred, sclerosed glomeruli here.
Yeah.
Again, I think it's the same slide with the PES stain. Just hints towards completely scarred glomeruli.
Yeah, they kind of look like fibrous crescents or something, but that's really not the case. This is just kind of how I believe this is how glomeruli scar down. It's just the process like you described. What do you see here?
So we have a trichrome, we have silver stain, sorry, a Jones stain. Here we are again looking for any ruptures, splits, or holes. I really don't see anything like, coming out strikingly. But I do see again the glomerular capillary tuft, they are pretty open. Here, right in the middle, I don't know if this is like as you said previously, maybe just like a part of the blood vessel that's kind of going into the glom. It's just the cut probably.
Yeah, probably.
But other than that, I don't see any mesangial expansion here. Maybe it's a little bit around this area and here.
Okay.
But the rest of it looks pretty good to me.
You really can't call it at the vascular pole. You have to go out more peripherally. And so you're right, it doesn't look that bad out in the periphery.
All right, again, well, this is a PAS stain, I believe, but the hair, sorry, this is a silver stain again, but just like looks pretty dark like the PAS. Here I can see again some portions of mesangial expansion, just a little bit here around this area too.
This is going to be a hard one to read because it also looks like it might be ischemic. So it's all collapsed down. You can hardly see the capillary lumens. And you see that periglomerular fibrosis as well.
Yeah.
Unfortunately, they're kind of high power or low power, so you really can't see anything about the basement membranes themselves or the, as far as the staining.
Okay. On the IF, we have IgA predominant staining, more so in the mesangial area, I would say.
A lot, a little.
I
Background?
think there's this, there's a little bit, it's not like all of the glom, just like certain portions of it, of course, it's patchy
Yeah,
rather
you
than
you
diffuse.
can't ignore it. It's not impressive, but you can't ignore it. I mean, that's IgA nephropathy, at least in that slide. It may not explain everything, but
Yeah, I think the key is this is certainly more than expected. And so it
yeah.
looks like it's
Well,
real.
0 was expected for
Right.
me. Yeah, go on.
Another one, more like patchy IgA deposition in the mesangium.
Then kappa lambda, everything else
And Congo red was negative, by the way, too.
negative.
So it's not a full
that-
house.
It's not a full house, nor is it an amyloid.
Next.
Right, so we have the electron microscopy here. Just to orient myself, this is more of like, I believe this is the vascular space here. And this is more so maybe the, and this is the urinary space in the middle.
That's right.
Here we have more so the mesangial area. Again, I do see there are some mesangial deposits on the EM2.
Good. That kind of fits with
and
what's on the IF. Good job.
Right, on the IM. So probably IgA predominant deposits in the mesangium. Other than that, the rest of the thing is important regarding the podocytes. I do see, I think they're pretty intact. I really don't see any
Good.
significant effacement either. Yeah, I think that's the main thing in this slide.
What about the wrinkling? Is that, it looks a little wrinkled to me. Would you agree? Not there, but down there, yeah.
Here?
Yeah, there.
Yeah, it does. Maybe it's just the collapsed glomerular.
Well, that's kind of what we see in core hypertensive nephrosclerosis. I'm not saying, just saying that's one of the findings. It's kind of predominant throughout that low power EM. Let's move on.
Again, so it's a better magnification. Again, I see the podocytes here pretty, they are intact. I don't think they are effaced either. And then here it would be the GBM. Again, probably these are the electron dense deposits that we just saw.
Yeah,
there.
I'm not sure. I'm not sure if that's what that is there or not. Steve, do you have an opinion on
It
any
seems
of
a
those?
little smudgy, or there's something there in the GBM. Is that right?
Yeah, I think this is just that fluff you see in sometimes with hypertension or ischemic disease where the basement membrane pulls, or the endothelium pulls apart and you get this fluff. And these are just some sort of organelles or,
Yeah, I think so. I don't think this was meant to
these
demonstrate anything other
these don't
than,
look like deposits at all.
yeah, I think it's just to show the foot processes are pretty intact.
Yeah, the foot process.
David was here, he
pristine.
would call those just cell processes.
There you go,
Okay.
cell processes.
Yeah, I failed you guys. Thanks, Casey.
Okay.
When in doubt,
So-
call it a cell process. So what's your diagnosis? What's your histologic diagnosis?
So it fits with chronic tubular interstitial nephritis. And then we have IgA positivity, probably unclear significance. It doesn't
Do you
correlate
think
with the clinical
this
scenario.
is just IgA nephropathy? You think it's two processes? I think you kind of said it was two.
I think if it was like an IgA, if it was the primary process, then the UA would have been kind of suggestive of more like the UA is completely bland here. So it doesn't go along with that. It looks like a predominantly tubular interstitial process. So I would favor more chronic tubular interstitial being the primary process, with IgA being maybe an innocent bystander.
Yeah, I think I think that's reasonable. Certainly amyloid was ruled out, probably oxalate was ruled out. We're gonna have to decide if hypertension is still in the picture, et cetera, or some of these familial things. Next slide.
I can't remember from the case, was there liver disease at all? She had a
No,
lot of diseases, but no liver disease, right?
No.
no.
So the pathologic diagnosis that came to Dr. Corbett when he received this case as a second opinion was advanced nephrosclerosis with moderate chronic tubular interstitial changes and IgA nephropathy. So I want to open it up. I think next slide's blank. Leave it there. I want to open it up to my panel. And I know Dr. Glassick did join us. I don't know if you heard the whole story and you want to comment, but what do you feel about, what does everybody feel about their pathologic diagnosis? And where do you think we are at this point?
I think
Casey, Bill, take
this is
over.
kind of a
Okay.
typical, this is a typical kidney biopsy finding in those autosomal dominant tubular interstitial kidney diseases, where it's basically it's a non-diagnostic, non-specific finding, and you have to go to genetic analysis to make the diagnosis. With that family history, to me, this is still, ADTKD from either uromodulin or, well, it seems like uromodulin because of the strong family history of gout, because usually the other two, the REN and the mucin 1, those are not as much of a hyperuricemic or gout family history. So I think that still to me is the number one. Or it could be, she may have skipped the autosomal dominance part, and she may have just Sjogren-induced interstitial nephritis, and this is more of a chronic process. So those two are still on top of my differential.
Yeah, I think
Yeah,
if she didn't have that family history, I would not think twice about just calling this interstitial nephritis from Sjogren's and move on. It's really the presence of the family history that would make me want to get the Natera genetic analysis. But I think it could be consistent with either, just like Casey.
Yeah, I'm impressed, Casey, that you were able to put the gout together with the way you did with the different disorders. Dr. Glassick, the family history was really strong for gout and renal failure. Was kind of what was screaming out. What are your thoughts?
Well, Roger, I came in a little late, so but I did see the family history, and personally, in a patient presenting like this with this strong an autosomal dominant history, I would have done genetic testing before a biopsy.
And that's a good point.
As you just pointed out, the biopsy findings in these UMOD MUC1 diseases are very non-specific and not diagnostic, but genetic information is. So
Well, that was
I don't
kind
know,
of
with
the
this
gist.
family history, I think you have to do genetic testing.
So that was the gist of the initial discussion. We asked if people would even biopsy, and a lot of people in the chat, the first thing they said was do genetic studies. Our fellowship group from, I won't mispronounce it, Geisinger or something, they came up with that very early. Kudos to them, because I think that may be the answer, and perhaps maybe the answer is genetic testing before a biopsy. I don't know the answer, but clearly that's not up for comment, because this came to Steve with the biopsy, which makes it great for our biopsy conference, and makes it great for Dr. Corbett to take over and tell us the rest of the story. Steve?
All right. So, Prabir, you're controlling things?
Yeah, I can control the slides.
Fine. So even the people that read the biopsy suggested something might be a little amiss. And it says, in the biopsy report, it says, although the diagnosis of IgA nephropathy is secure, the morphologic characteristics and distribution of the deposits do not appear to adequately account for the severe nephrosclerosis and significant tubular interstitial changes observed in this biopsy. And so even they thought, something was amiss. And when we saw this lady for the second opinion, as has been pointed out, this strong family history with gout and tubular interstitial disease, I called a friend of mine who's got this as a primary interest of his, Anthony Blyer, down at Bowman Gray, Winston-Salem, and asked him if he would, evaluate the family. And he was more than happy to. I can't tell you how difficult it was to get the family and the patient to actually follow through. It actually took several years, in all honesty. We found out, that they finally got the evaluation done about 6 months ago. And so we had him, look at things to see whether or not, in fact, there was a mutation. And as an aside, unless it's changed, I think Tony's the only one that can do the MUS1 evaluation. The other ones, the UMOD and the RIN, can be done through Natera. But for whatever reason, the MUS1 is not on the list of mutations they look for with at Natera. So the next slide. So we finally got the evaluation done through Tony's lab. And sure enough, MUS1 mutation was, frame shift mutation, which is what they usually are, was detected. This was previously called medullary cystic disease type 1. Next. And so Tony has a really nice paper in Advances in CKD that kind of gets into these. And MCKD type 1 was the MUS1. Uromod is it would have been medullary cystic kidney disease type 2. And then the autosomal dominant TKD RIN mutation was previously talked about, or called familial juvenile hyperuricemic nephropathy. These are all autosomal dominant. The uromods on chromosome, the genes on chromosome 16, the other two are on chromosome 1. As in this case, they all have a bland sediment, no protein or hematuria usually, which is really what makes IgA almost, hard to understand unless it's just kind of an innocent bystander that was trapped there. I was trying to find out if patients with Sjogren's have IgA trapped, and I didn't really find much. For sure, the ANA and the low C3 and 4 can be seen in Sjogren's, and apparently the mildly depressed complements are usually associated with more active disease and an increased risk for non-Hodgkin's lymphoma, which she never developed. But anyway, those serologic findings may be explained by the Sjogren's. She, in fact, had this MUS1, which the gout rarely is, unlike the other two, gout's not really as common. And it basically occurs as the patients develop CKD, and they develop hyperuricemia and can get gout with that. But it's not like you see it in childhood, like you do in the UMOD and the RIN. Again, the age of onset's in the mid-40s, or at least progression to end-stage renal disease. We'll get into this a little more. All of these have to do with intracellular deposition of these various proteins, which lead to apoptosis.
Well, I think that's absolutely, I'm sorry, Steve, I think it's absolutely incredible, because the gout history wasn't subtle. It was everybody had gout and renal failure.
No,
and
except
as you point
her.
out, that's true. Good point. But except her. Well, maybe there's two different mutations in the family.
Well,
but,
and again, I don't know when the gout started. In these others, it starts in childhood. I don't know.
Well, I've got patients. I have a family with it, and neither of them have gout. The mother had end-stage renal disease from this. Neither of them have gout, but they both have hyperuricemia. Now, and she doesn't have the hyperuricemia. I think you mentioned that some of the patients might have gout, but that's just related to renal failure. But renal failure is a mild, if anything, risk for gout. So I don't have an answer here. I just think it's absolutely remarkable that we've got this extremely strong family history of renal failure and gout, and yet it's the wrong gene here. And it led to the study, but yet it's still the other gene. And as Casey pointed out, I don't think you said it's very rare. I don't think it happens. I think if it does happen, it's a coincidence. I don't think they get gout. Houston.
Well, you're talking about with the MUS1 mutation?
Yes.
In Tony's papers, they get it, but it's generally related to CKD, they say.
That's my point, yeah.
Yeah, but it's, whereas, and as far as treatment, there's none known. Now, the Uromod is, TAM Horsfield protein, again, autosomal dominant, they get gout. Now, the interesting reason that they may get gout, at least one of the explanations, is a decreased amount of normal uromodulin actually apparently leads to a decrease in the furosemide transporter in the thick ascending limb, which is where all these things are affected. And by having that the decrease in that transporter on the apical surface, they apparently get a natriuresis, which then leads to increased salt or sodium and uric acid reabsorption proximally. At least that's one of the explanations as to why this group may get gout at a young age. Again, it's a result of.
That's really interesting, because sometimes in the old books they talk about salt wasting with these disorders.
Well, in this one, that there is a mild natriuresis, they say. I mean, for sure, with the RIN abnormality, they become hypotensive because they're essentially, it's like giving somebody an ACE inhibitor. With uromod, again, there's the mutated uromodulin builds up in the cell and then leads to apoptosis and loss of function. And then allopurinol has been used to treat this. And then the one that I have to admit I didn't know much about was this, autosomal dominant TKD with RIN mutation. Again, it occurs in childhood. The gout occurs in childhood. They usually have significant edema, hyperkalemia, hypotension. they have some salt wasting and that can develop acute renal failure, which is one of the presenting features that they have. And again, intracellular deposition of mutated renin and again, most of these affect the thick ascending limb. And a high sodium diet and mineralocorticoid replacement is the therapy. The next, these are
It's kind of remarkable. 3 very different treatments. One is allopurinol because maybe uric acid is somehow related to the pathophysiology of the progression. One, we have nothing to offer, and the other one is basically treating salt wasting.
Yeah. Again, at the end of the day, the real problem here is the buildup of these proteins in the proximal tubular thick ascending limb, which leads to, damage and apoptosis. And MUS1 apparently is one of many mucinous proteins lining epithelia. Forms a carbohydrate tree protecting the cell, which it shows there in the kind of green outside of the cells. And this protein is both in and outside of the cell, which is trying to show you there with the brown, with kind of the beige cytoplasm. It's expressed in the thick ascending limb, loop of Henry, and the distal convoluted tubule. This protein is also found in lung, bladder, sebaceous glands, breasts, and it's interesting. The disease only affects the kidneys. And Tony and I were talking about this earlier this week. He thinks part of the problem is that these other cells, these epithelial cells, turn over a lot faster than tubular epithelial cells. So, the buildup doesn't really result in any major dysfunction to those cells, unlike the kidney. The next slide. So these mutated proteins apparently deposit in endoplasmic reticulum Golgi intermediate compartment, if that's not a lot to say. And that's what it's trying to show here, is where the protein with the mutated protein has the red terminus on it. This basically backs up in the cell, leading to damage and apoptosis. And again, it only affects the kidney. His theory is because these cells don't turn over as rapidly as possibly other cells, so that the deposition doesn't get as great in those other cells, and the cells are sloughed and then regenerated. The next slide. There's been no real therapy for this, but apparently there's a drug BRD 4780, which binds the transmembrane trafficking protein 9, TMED9 vesicles, and releases the mutated MUS1, rerouting it into lysosomes, and it's cleared from the kidney. And so what it's showing here is in a healthy kidney, the MUS1 isn't building up, whereas in the diseased kidney, you can see it building up in the cytoplasm there. And with this drug, it releases it and transports it into a lysosome where it's then destroyed. And apparently, this was an article that Tony sent me from Cell. Apparently, this is something that's being looked at the present time. And I don't think obviously it's not available for use, but it's something that might be promising. They're suggesting it could be used in the treatment of any of these 3 diseases. Next. So in Our Lady, sure enough, over the course of several years, over 4 years, her renal disease continued to slowly progress, and sure enough, she went on dialysis. Now, she's on the transplant list, and the good news here is that these people do very well with the transplant, given the fact that it's not unlike other genetic diseases that affect the kidney. And so she's waiting for a transplant. The truth of the matter is, as recently as a few weeks ago, Tony is still trying to get a hold of the 2 brothers and her oldest son to get those patients, to get them tested as well, just to kind of help put the whole story together and kind of tie up the loose ends, if you will. And the last slide.
It took so long to get her genetic testing done because of all those issues. You didn't really know until recently. So did you think about treating her maybe with steroids or something like that in case it was a interstitial arthritis from Sjogren's, or maybe treating her Sjogren's with something CellCept or anything like that?
No,
obviously you've been wrong in retrospect, but since you didn't know.
No, she was on Plaquenil for her Sjogren's. It was a lot of chronic disease and not a lot of acute. And I was my concern is that there'd be more side effects from the steroids than any benefit. We continued her on the ARB. The angiotensin 2 does increase TGF beta. Obviously that that hasn't helped much because she had a lot of fibrosis. So for whatever benefit that gives, along with controlling her blood pressure. But no, the truth
Well, you
of the
don't know.
matter
I
is,
mean, you don't know what she would have done without it. I mean,
well, that's true. I mean, like I say, she was put on it early in 2015. It was at the same time as or 2016 at the time of the biopsy. So she'd already had a lot of fibrosis. Had she been put on it sooner, maybe there would have, maybe it would have slowed down some of the fibrosis. But anyway, but the answer is no. We weren't going to go for anything more immunosuppressant. We kept pushing her because our feeling was exactly the same. I thought for sure she was going to have the uromodulin mutation because of the gout. I mean, that was just such a strong feature. And this is just a summary slide from Tony's 2017 article. It just says these are the primary causes of autosomal dominant TKD. They need to be suspected if a parent and a child, in this case, the mother and father didn't, to our knowledge, but her brothers and a maternal uncle did. So there was a strong enough history, and she had a bland urinalysis. And again, variable progression, but in her case, not unlike what's being described here, she progressed end-stage renal disease in her, probably in their mid-40s, essentially. So I will leave it at that.
yeah. So, what a circuitous course to make that diagnosis. Kudos to you to take it to the next level, which is what a second opinion should do. Try to not just accept what's going on. Kudos to everybody. I think it was really a well-discussed case and a very unusual case, and something I don't know that we're going to see. The ones I've seen have already had a diagnosis or weren't biopsied, but I think this is a great venue for that. Does anybody know of any other promising, ideas out there, treatments, and any thoughts, Dr. Glassick, about this?
You're muted if you're still on, Dick.
That's all right.
Yeah.
Well,
I got it.
thanks. Okay.
Can you hear me now?
Yes,
Yes.
yes.
Well, Roger, I think one of the points that is made in this case, and I've seen it in several others, is that kidney biopsy really doesn't define a diagnosis. You wind up with chronic interstitial nephritis of uncertain etiology, and then as an afterthought, you do genetic studies and you find out what the real disease is. Just to illustrate this point, many years ago, I was called in to provide testimony in a medical legal case involving non-steroidal anti-inflammatory agents, which were alleged to cause chronic interstitial nephritis and kidney failure in a patient. And after many years of follow-up, the patient eventually did have both a biopsy and a genetic test and turned out to have autosomal dominant tubular interstitial kidney disease. And it had nothing to do with the non-steroidal anti-inflammatory drug exposure. And I think I wish we were doing genetics more routinely in non-steroidal inflammatory disease alleged chronic interstitial nephritis, because I think we may find that a lot of these patients really have an underlying genetic disease.
Yeah,
That's
and
a
I think
great point.
We're only going to get better at this. Steve, does she have any children? Did I miss that?
Did she what?
Does she have any children?
Well, yes, her oldest, yes, I think it was 4 children. Her oldest son has some chronic rising creatinine, so that they're trying to get him tested as well.
Okay, yeah.
I think the other point here is, I couldn't agree more with Dick, Dr. Glassick. I mean, for one thing, Natera, that they have an amazing ability to test for, I forget how many, 150 or I forget how many different mutations that are associated with kidney disease. And so at least with the UMOD and the RIN, you can get that tested. But Tony, his on the one slide, his email is there, and he is truly one of the nicest people and is more than happy to take the reins when you give him the name of a patient you want him to evaluate and get it done. I mean, I've had several other patients who he's evaluated, and he takes over and gets it done. I mean, it's very nice. And so that until the MUSE1 is out there and available through a reference lab, he's more than happy to do it for people. I mean, this is a real focus of his, especially MUSE1. So
he's built a career on it, but
he totally has.
A lot of people build careers, but they don't make themselves that easy. You just, anytime a case comes up in communities, he leaves his email. He says, send me the blood or let me know and we'll work it out, which is,
Yeah, and he doesn't charge for it, partly because I think he's enhancing his pool of patients, which good for him,
Yeah, well, good for him, because not everybody's able to do that. And I think that's a real, we're lucky that he took this disease on, and that we have a world authority, that not only a world authority, but someone who's able to help us out with the diagnosis. And so easily you can call him on the phone, it's just on first name basis. So I think we're going to wrap this.
One last maybe point is short of that is just like you said with the Natera. I mean, 5 years ago, the common line, and anybody that you suspected that had any genetic disease was, it's not going to change our management. It's very expensive. It's not going to be worth paying it out of pocket. And so we're not going to do it. And then we're left with learning nothing. And then we're left with no future. And now that Natera is basically being, it doesn't get all of them, but it gets a whole bunch of genes, just like you said, using them has basically taken that part out. And I've done several of the Renocyte Natera tests that I probably wouldn't have back in the day. And hopefully that'll lead to, future generations being helped out more.
Well, not to keep plugging this particular lab, but I have to admit, compared to some of the other labs, it's a heck of a lot more reasonable. They do a lot more evaluations. And I think if there's ever a cost to the patient, my recollection was it's never more than $300, which is unbelievable. I remember when we were just getting Potosin mutations, looking for those, I think it was $600 just to do the one evaluation. So I think it's definitely a great tool that we have, and we should start using it more often. And I've tried to. Some of the problems are as when you start looking for things, you find things you weren't expecting. You don't know how to interpret them. And I have to admit, the lab, not to belabor this, but the lab actually has professional genetic people to help you with some of these other things that might come back that you're trying to wrestle with. What does it mean?
Yeah, and that's real helpful, because it's like the cancer gene testing now. You're looking for, for a one gene and they find some other gene, and they've been pretty good to tell you what is probably meaningful, what is not. So I'm going to wrap this up. Great case, great discussion. Thanks everybody for joining. Make sure you join our YouTube channel. We'll see you next week. And until then, everybody stay safe.